journalism. Thank you very much for serving people. Thank you very much for working so hard. Please cater for yourself as well. There's also the principle of honesty and transparency. Let me tell you, ladies and gentlemen, can you imagine even animals know how to cross roads? I see goats are better than dogs at crossing roads when a vehicle is approaching. But if even animals know how to cross roads, if even chicken can dodge a truck, what about humans? Let's be honest and tell patients what is known and what's not known. Let's not pretend like we know everything. Let's not take advantage of our knowledge and obvious power differential. So in ethics, we teach that the doctor, the surgeon, the healthcare worker is above the patient. And the patient is in a form of predicament. It's like he's imprisoned by the scenario, by the disease before him or her. We have the knowledge, we have the tools, and we have the means to save this person who is fallen in the pit. But let's not take advantage of that situation to decide for them. Let's not take advantage of them to dictate over them what should be done. Let us be honest. Let us be, for example, honest at disclosing complications, disclosing near misses. I don't know how many times surgeons tell patients what actually happened when they're in theater. Supposing you had the wrong vessel, but during the context of surgery, you happen to anastomose it and correct your error. How many of you are willing to post-op, as you discharge the patient, to say, by the way, during the procedure, I had made this mistake, but we did this and we corrected you and you'll be fine. The concept of medical errors, right now in the US, the laws enable healthcare professionals to disclose their errors. And once you disclose your error, you are immune to prosecution. To the best of my knowledge, Uganda doesn't have that in the law yet. So organizations like Uganda Medical Association should press for that law so that we are covered when we disclose our errors, we are covered against litigation, against being sued. It's not ethical to do cover-ups. You should tell the community what wrong you've done. When you keep doing cover-ups and hiding, it's a lot of errors in the practice and the errors in the profession. I hope many of you know that the people who led to the release of COVID-19 from the lab to the meat market did a cover-up. And up to today, China has never agreed that they are the source of the COVID-19 epidemic. And we are also aware that this COVID-19 was in an American lab in Wuhan, and even the Americans have never disclosed. So you can see, try to borrow that to our medical profession. How many lies are we covering up on our patients? If you have financial ties between in the medical business, now in some jurisdictions, including Uganda, if you have shares in a hospital, you're supposed to declare to the patient whom you are treating that you have shares in that medical enterprise. This is to avoid the conflict of interest. So if you have a unit where, normally surgery brings in more money than other branches of medicine, both surgery and obs-gyn. So if you have a unit that is dependent on private patients, you need surgeries, you need procedures. Now, if you are doing endoscopies, if you are doing colonoscopies, if you are doing various kind of surgical procedures on your patients, I'm sure all of you know about the issue of cesarean sections. We have one of the highest cesarean sections internationally speaking, and many people believe that this high Caesar rate in the country is driven by conflict of interest. It's not driven by cephalopelvic disproportion or other issues that mandate cesarean section. So you must be able to disclose that I'm admitting you in this hospital and I'm proposing this surgery, but I have shares in this hospital. In some countries, when you don't do that, a patient can sue you for not having this clause that you are making money in that same unit. There's also issue of being truthful to colleagues and being truthful to regulators. Ladies and gentlemen, we, as a noble profession, we must learn the art, the science and art of being truthful. And also remember that you can never, you can hide, you can hide in errors, but only for a short time. Truth will always triumph. Truth can even come off posthumously when you are long dead and spoil your legacy. So be careful to be truthful to patients, to be truthful to colleagues, and to regulators. Then there's also the principle of caring for the whole person and not the pathology. This has become a modern kind of diversion where people just treat what is standing before them. You've seen these patients, these people who say, oh, you've got Brucella, and then they give you 60 injections of streptomycin. Sincerely, even if it was Brucella, how many of you would want to have 60 jabs of streptomycin in your bums? Now, you must see the person behind those images, those CT scans, the person behind the histology. You must value this person's values, their beliefs, their expectations. Supposing you are planning a surgery without even asking a person that, oh, next week, what do you intend to do? You know, you must remember that these surgical procedures impact on somebody's employability. You want to do a surgical procedure, an elective procedure on a person who has an interview in the next 3 days. You know, first of all, ask the person, is it the right time for you to have this procedure? Those of you who are dealing with infertility, surgical procedures for infertility, for example, there are so many choices. There are so many alternatives. Will I have IVF? Will I have tube or whatever? Insufflation? Will I have this? But who are you to decide for this person? You know, to choose between artificial insemination and this and that. It's not you. First, look at the beliefs of this person. Look at the expectations. Value the person before you. Don't just value the procedure. You must carefully navigate conflicts in judgment. For example, we had a patient who had a MEN syndrome, a MEN 2A syndrome, who had a pheochromocytoma. He had a big adrenal tumor, and it was very obvious that you cannot do thyroidectomy before handling the pheochromocytoma. But this patient didn't want a thyroidectomy for cosmetic reasons. The surgeon knew that she could not carry out the thyroidectomy before handling the adrenal. And so a conflict ensued. And the patient wanted, didn't want the procedures that the surgeon was whatever. He wanted the thyroidectomy, but not the adrenalectomy. So how do you navigate such a conflict? Knowing very well that the moment you put this patient on this, you're going to lose the person. And also remember that when you are describing these conflicting situations, you are not putting nuts and bolts on a vehicle. Vehicles don't complain. They can quick and make some sound, but human beings complain in a different way. They might vote by walking away. I'm sure many of you know the term loss to follow up. Some of you who do research know how painful it is when a patient walks away from you and doesn't return for a procedure a month later when you're really looking for an outcome. It's because people are people. That famous statement that people are people should be very... So this whole personal approach is what a good doctor does. Collegiality, team spirit. Sole player are things of Edward Jenner and old-time doctors. These days, it must be a team spirit. And that's why we physicians cannot handle Ebola without the surgeons. One of the most vulnerable patients during the Ebola epidemic is the pregnant woman. And many of them have come to give birth in Ebola treatment room. So how do we handle that without the obstetricians? Now obstetricians will say, Ebola is for is for physicians, and then you leave us to handle. So it's about collegiality, it's about team spirit. Now within teams, there's what we call conflict management. A good doctor should be one who can handle conflicts, because there are always differences in opinions between seniors, between peers and juniors. There's no such given thing that we shall always agree on everything. We are like society. You saw what happened in parliament when people were boxing each other. And up to now, some people have injuries from that altercation. The same can develop in healthcare delivery, where you find people actually fighting. It may not be blows, but it may be verbal comments. It can be bad blood between this surgeon and between that surgeon. I'm sure many of you in your training, you had farms where so-and-so couldn't talk with so-and-so. You should avoid humiliating others and demeaning them, and avoid what we call professional arrogancy. Now, I want us to turn to a very difficult topic. It's about the modern surgeon and profiteering. Is it ethical for the surgeon to profiteer off people's illnesses? To what extent should a surgeon benefit from a surgical procedure? Should there be a cap? Should it be left to open market forces? There are those of us who believe that it should be capped so that there's moderation in our charges. There are those who argue that no, medical service is like any other profession. If I'm going to do an open heart surgery, total anomalous venous return, and very whatever, I should charge what I charge, should be left to that. There are those who argue that that is wrong for the doctor. Now, looking at the positive side of profiteering, it's a very good thing that incentivizes people to take risks. Why do doctors go for long-term training? Those of you who have been to the US, you've seen people becoming 40, 45 when they are still doing fellowships. They are willing to take the risks because they know that they're going to make trip big. So it's an incentivization if you work in an area or a subspecialty that gains you money. Or, why is it that people go into cardiology and now people are going into interventional radiology? And why are people going into laparoscopic surgery? Because they are incentivized by the profits they like to gain. So that's positive. It incentivizes innovation. It incentivizes long-term planning and career development. So all these are positive things that we should consider. And high profits encourage morally upright competitions, leading to increased quality and cutting costs. So people say, so in other words, we should leave it to market forces, let the profiteering be there. The president, for example, has been calling for medical tourism. They are building Roba Hospital and other ventures. The UPDF now have a hospital in Imbuya and many other units. And I think some of you here are in the private sector where you are putting up, units. I think units like Rubaga Hospital want to do liver transplants. How are they going to do it if there's no profit out of it, the procedure? And how are we going to have other private hospitals come on board and be like hospitals in the US, Cleveland clinics and the like? How do we? So incentivization is very key, and we should look at that side. However, there are the negative effects of profiteering that we should look into. If you focus on profits, you may lose the goal and purpose of what you are up to. And this is what Aristotle calls bridling. You remember the bridles on a horse? A horse which is unbridled goes wild. But when they put a bridle on a horse, there's a way they can control its movements and its actions. So yes, profiteering is good, but don't just let it loose without controls. You can have conflict of interest and serious erosion of morals. For example, I've been wanting to talk with you surgeons about indications for some of these procedures you do. Almost every patient who goes for endoscopy, I'll not mention the units where this happens, is told that you have hiatus hernia, and they're given the grades, the levels, and therefore you must have laparoscopic surgery. So you begin wondering, why is it that almost all patients are told the same? You begin seeing that somebody has seen, I can charge such and such good money, and therefore let me do these upper GI endoscopies, and then I can make it big with the. So you begin to erosion of morals. I'll tell you of a cardiologist here in Kampala. I'll not identify him, but he used to do endoscopy. No, he used to do echocardiogram, echo and ECG every month. And if a patient didn't turn up for the monthly echo and ECG, he could quarrel and even tell them that you must do the missed ECG must be done. So a patient would do 2 echo ECGs the following month if he missed the one of the previous month. And each echo ECG diode was costing 400,000. So there's one patient who had gone through it for 4 years until he began putting one and one together. I said, why is this cardiologist telling him to do echo and ECG once every month? And it's only when he went for a second opinion that he got an answer that that doctor was just fleecing him off. So there's a lot of loss of community trust when people see us that we are just detoothing them. And when people begin doing easy, there's what we call administrative convenience. You do things which take less time as opposed to those which take a long time but will be more beneficial to the patients. And then there's this elephant in the room. How would you incentivize people who are working in interesting places like emergency medicine or education settings, which are not fitting for those models of profiteering? What about, is profiteering ethical during times of duress? And this is where it gets us back to my discussion on the noble profession. If it is a time of Ebola like now, and patients come in for surgery, it's a time of duress. And then the surgeons begin saying, I'll cut you if you pay double. Anti omanyi munange biseera by'Ebola. It becomes unethical if we extract gain from people's vulnerability. It's very unethical. If there's a strike going on and you meet a patient and you say, me, I'll work on you if you pay me 4 times the usual cost, it becomes unethical for you to do that. And you can see from my second bullet that I have a bone of contention with the surgeons withdrawing their services during epidemics of viral hemorrhagic fevers. And don't take advantage of others because they lack alternatives. For example, there are those who put their clinics in strategic places because they know that this is a bad corner. There will always be accidents around here. So don't be so unethical. Don't monopolize specialized skills and or access. If you know that the only one who can work on a certain skill, please make sure you mentor others in it. And don't leave things to government. Even if you're in private, please share services with the government sector. For example, why should the private units exempt themselves from handling public health responses? Those things of Ebola, those things of COVID are for government. As for us, we are out. No, it should be part of the response. There could be some aspects of surgery that should not be left to market forces. Why, for example, you see club foot. It happens a lot in our communities, in the villages. And you know, these orthopedic surgeries, especially those that require implants, are very expensive. Now, if we left this to market forces, really, are we being ethical? How will the person in Kalangala Island have a club foot corrected if we are saying leave it to market forces? So when communities are in duress and times of duress, ladies and gentlemen, it's a clarion call on us to ensure that we come in and be noble and be proud of it. I know it is extra work. I know it's extra stuff to bear, but that is the calling that we should have before our people. For example, we must draw the lines. There's what we call drawing ethical lines. There's that surgery which optimizes value and is innovative. And then there's surgery that is just profit making through coercion, deception, and creating artificial shortages. It's very common in Uganda for people to create artificial shortages, you know. You'll excuse me to make some of these examples. You go to book, for example, for an endoscopy, and they give you 3 months, that you come back after 3 months. But the same people who are working in a private clinic nearby will work on you on the same day. So you wonder, why are they creating this artificial shortage in human resource, artificial shortage on theatrists, artificial shortage on so many things. So we should be careful. Now, when financial gains override duty of care, it becomes unethical. Let's not deny life-saving treatments to patients because they're not able to pay. Now, this has become a very, very big problem, that even people hold dead bodies. And I'm sure you've seen even the government had to come up with laws that make it illegal for you to hold a dead body. Now, I don't know how people circumnavigate this in a private. I know that people sometimes do it by referring the people to Mulago, but sometimes it becomes unethical if, for example, if the surgery is to achieve hemostasis in a burst abdomen and you are in a private hospital, but the patient doesn't have money for a second surgery, for a second appearance in the theater, are you going to refer that patient to emergency in Mulago? I'm sure many of you do it, but it's unethical, you know, because the patient cannot pay for the second operation, yet you have already eaten the money. I remember during the COVID pandemic, we had very big problems with the private units. They could milk the patients, and when people were dry of money, then they say, go to Mulago. I mean, somebody's in your unit saturating on 30 of oxygen, and you're referring to Mulago, and it's going to line up in the line near Ward 1A. It becomes unethical. So let us be careful about money. So pay before service becomes very morally inept when you are dealing with the emergencies. And I really want us to seriously discuss this. What are we going to do? Our people are poor, and people begin saying, let them not put their poverty on us. Those are the excuses. But this is the context in which we are serving health services. Our people use out of pocket, what they call catastrophic healthcare expenditure. They are using out of pocket expenses. So what do we do? Can't we pass that for truly deserving emergencies, they should be served before we talk about money? So denying bodies of demised clients and denying immediate surgical services to patients who would otherwise irreversibly be harmed by that act constitutes an ethical act. There are dilemmatic areas, the issue of sham surgery. For example, in research, is it okay to allow randomization of people into sham surgery? It becomes very dilemmatic and a gray zone. Then a lot of stuff, a lot of problems, issues have been put on the side of the doctor, but there are times when patients are the people who are promoting a wrong. all of you have come across people who demand illogical procedures. I had one time a patient who came to see me, a lady who 33-year-old with UTI, and had the culture and sensitivity results that was resistant to all antibiotics except one. And she came and brought it to me, and I examined her, and I told her, I'm going to make use of this culture and sensitivity, and I'm going to prescribe for you this only antibiotic that is sensitive. And the lady looks at me and says, no, I don't want that. You give me one of the others, which is resistant. And I look at her, and I kind of think this lady is maybe not okay upstairs. So I refused it. I refused, and the lady says, no, please write for me one of the resistant antibiotics. So I normally don't do it, but that day I did it. I prescribed for her the resistant antibiotic. And to my surprise, the lady turned and thanked me very, very nicely, more than any patient had ever thanked me. And she told me I'm the best doctor that she has ever come across. My brain began turning around and said, why can't somebody thank me for stupidity? And the lady went and she used the resistant antibiotic, and she came back and she had improved. So I really got confused. Sometimes you come across humbling experiences of that sort. Now, involvement in state or court-required procedures that invade clients' rights. In many jurisdictions, in many countries, doctors are not supposed to be involved in, for example, capital punishment. For example, it's not doctors who carry out death sentences, the lethal injection and all that. It's not noble for you to do that. So make sure you don't do it. Then for insurance, many of you are involved in insurance companies that erode clients' rights. For example, they put limitations on antibiotic use, and they make you prescribe very lousy antibiotics. They come and tell you this patient is on a silver plan, and the only antibiotic he can have is Pen-V. And you look at the patient, he has already used the Pen-V for a week, and the disease is increasing. And again, you are supposed to prescribe the same Pen-V. So how do you circumvent that kind of dilemma? Then there are those of you who are faced with the institutional goals, when they impact on institutional financial goals, when they impact on client care. I'll not disclose to you the unit, but there are hospitals where the director, private hospitals where the director gives you that this month you must do you must remove 8 appendixes, or you must do 12 herniorrhaphies, you must do this. There are people who are put on jobs and silently they are given those terms of reference because they tell you we have to raise your salary. So you go, and every lady who comes in, every young girl who comes in and has dysmenorrhea, you cut appendix. Whoever comes in PUD, you cut appendix. Whoever comes in with this, you do this, because you've been given a timeline. So what do? If you don't do it, you are sacked. If you do it, you do morally inept things. We call this, you enter into a situation of moral distress. So we have to discuss how we handle moral distress. You know what is to be done, but the situations are making you unethical. For example, many of you work with the people who come in as volunteers. I see quite a lot of them in casualty, A&E. Why would a doctor work as a volunteer in A&E for a whole year? And petrol has become petrol, diesel has become diesel. This person keeps, it's because this person is now conflicted and is making money. Then handling conflicting decision makers, dual role. Some of you are carers and researchers at the same time. And I've already mentioned the issue of industrial action. These are just, as we come to a close, the principles that you are to follow. Make sure that you benefit your patient. Make sure that you're not malefficient or bad to your patients. Give your patients autonomy, and do justice and stewardship in resource allocation and use. Have integrity, and don't just do defensive medicine. Don't just look for volume outputs. Be humble, be teachable, Be good even when no one is watching you. And there are other practical issues that we all go through that we are going to end up with. Issues like, when do I operate? When don't I operate? Please involve your clients, involve their families in making these difficult decisions. Also, I see many of you don't involve the administration of the institutions where you work. Please, whenever you come across a dilemmatic situation, please inform the ED of that institution, inform the director of that institution. Don't handle morally troubling bedside ethical issues by yourself. A hospital like Mulago and many of these big hospitals are supposed to have hospital ethics committees, even including private hospitals like the missionary hospital, the big-sized hospitals. If you look at a hospital like IHK, it's a university hospital, I think. If you look at all these kind of medium to large-sized hospitals, they need hospital ethics committees, something that we have failed in Uganda to popularize. Government has failed to bring it in. I'm yet to be advised of a private hospital that has a hospital ethics committee. Advise me if it is there. I would love to relate with it. There must be meaningful informed consent. Informed consent is not just sign here, sign there. Don't just do defensive medicine. Some of you fear to be taken to court because you never did the MRI, so you do MRI on everybody. Toothache MRI of the foot, toothache MRI of the uterus, because you fear to be blamed for not having done ABCD. Team dynamics, I've talked about them. Healthcare financing through insurance companies, very big ethical issues, and I mention it because this is where the world is taking us. In the next 5 to 10 years, most of us will be under insurance, and all these issues have to be discussed. Handling complications and errors that we do by the bedside, and being a good steward of inputs in relationship to expected outputs. Right now, many of you have seen how government has put in a lot of, not only government, but even the private sector, the clocking issues. Those of you in universities, everybody has now asked us to clock in, but you've clocked in, but some of us clock in and just move around. You still find that the inputs are not there. So a good and noble doctor is one who just doesn't come and clock in and then keep moving around, having done nothing, ensuring that that the outputs out of your service as a clinician really meet the inputs that others are putting into you. As I conclude, I want to remind members that never before has there been such a need for a virtuous medical profession like today. And the world is critically looking for virtuous people. They're in short supply. It's looking for virtuous medical professionals, particularly the virtuous surgeons, who are not going to operate you, who aren't going to manage you conservatively because you don't have money, yet they would have managed you actively if you had had the money. We should start by self-introspection. Let us not point the fingers to others. Let's look at ourselves and judge ourselves. And lastly, the issue of modeling others. I'm sure there are very many teachers here who are teaching people, either teaching your peers or teaching your seniors or teaching your juniors. We are all in a teaching kind of model. And I really want to leave that with you to just ask you that, to what extent are you modeling others? To what extent are you mentoring others into this discipline? Thank you very much for hearing, and I would like to listen to your comments, complaints, questions. Usually in ethics, we also talk of discussions, additions. So I would like to end here and listen to you. And back to the moderator who can guide the discussion time. Thank you very much.
Thank you so much, Dr. Nakwagala. I'll be taking over from now. Dr. Ogwal is hosting the PS in his district, so he couldn't continue with this. but it has been a very I'm sure all of us right now are trying to place themselves on what qualities they have or what they need to work on to improve and be a better doctor. We've talked about a lot on ethics and how to prioritize our patients, use wisdom to relate with our patients and colleagues, and also given a challenge to our associations to us. So, and the question was posed on what alcohol level is does the surgeon need to have? What's the minimum alcohol level required for a surgeon to operate? Maybe this is something a SO can pick up and do. And to UMA, how to protect the doctors who disclose errors to the patient so that this can be done and improve ethics in our profession. At this point, I'd like to open the floor to questions. Feel free to post in the chat or put up your hands or even unmute and speak to us. Yes, Dr. Olivia, please, the floor is yours.
Good evening, good afternoon, Dr. Nakwagala and the ASO members and other people present on this Zoom call. I think this is a very introspective and inspiring talk given by Dr. Nakwagala. Thank you very much. I would like to ask your opinion about the issue of moral distress that comes about when a surgeon is required to give particular care, but because of other circumstances, institutional circumstances, the surgeon is unable to give that care. And at the end of the day, it comes out the patient is the one who suffers, and yet there are institutional problems that are contributing to this kind of problem. How do we go about handling those challenges that we face? An example is like many of us work in institutions where there are shortages and challenges. I'm not talking about the private sector where everything may be available at a cost, but you're working in a public institution, you know that you sometimes don't have drugs, you don't have sundries to do the best and offer the best you can for the patients. How do you deal with that moral distress of trying to find a way of giving the care you should give, and yet circumstances make it impossible for you to do that? Thank you.
We get more questions?
Yes, Dr. Igaga, please go ahead.
Good evening, everyone, and thank you for Dr. Nakwagala for this talk. I'm Elizabeth Igaga. I'm actually an anesthesiologist. My question to you is, I understand the ethical bit around, payments and pay before service and that kind of thing. And I totally get that. But I think there's one part of the puzzle that every time we're having this ethical discussion, we never talk about. At the end of the day, someone has to pay for the things that are used on a patient. Someone has to, that stuff is bought. You can't go to, JMS and say, because, we get emergency patients, please give us things for free. So I wonder where the balance is and how to figure out who eventually pays that bill for a patient who has ended up in a private facility, for example, but cannot afford what the life-saving situation would be, and is there a policy that would be able to protect the staff that actually end up doing that? A lot of times, if a surgeon or an anesthesiologist goes ahead to do that, sometimes they're threatened with even their own pay being taken to pay for the patient's expense. So do you know of any policy or any ways that the patient can be protected, but also the health worker can be protected, and the places that are offering these services, whether government or private, are able to recover the cost of the I guess, sundries and resources that they have used on the patient. Thank you.
Thank you so much. We have another hand up from Malone. Please go ahead.
Yeah, thank you, moderator. Thank you, Dr. Nakwagala. I think your presentation is really very touching, and it puts us in a lot of self-reflection. But I wanted to put a concern on the environment under which we operate. One thing I want to highlight is that most doctors, they are fully, they not, it may not be fully, but to some extent, they are aware of some of these ethical dilemmas that they continuously continue to commit. But the reason is the environment under which we operate, because we know we are pushed by other non-medical social issues to commit some of these events that we really enter into. Now, I want to put a case in point comparing particularly the medical field plus other professional fields. Like the legal, the lawyers, also plus other professionals. So you find that the point I want to push is at that level, is there a way you people have as senior professionals? Is there a way you have that professional discussions where there can be an environment of equity that should be created? Because sometimes we feel very unfair. Like you find that I go to a lawyer charges me 500,000 for getting a service. But now me as a doctor, some of the service that I give, somebody can look at it like the public really views it. Yes, it might be very true that health is really a universal demand, but of course also we operate and sometimes equity is very, very key. So I'm trying to try to think, Dr. Nakwagala, is there a way that at that level, you can also interact and create some bit of equity that could also be able to strengthen the ethical stand in which we operate? Then number two is, yes, we know sometimes us as the doctors, we do commit some of those issues for those social reasons. But also, again, how is the law also protecting us? How is it also handling the public in events where we get some of those outcomes? Maybe I've treated a patient, the patient has not paid, I've done emergency care, the person has not paid. So you find it becomes very awkward for you to really raise such a concern. I don't know whether legal, but sometimes it really sounds very awkward. So if the law should also be able to there to try to see, maybe with the coming in of the insurances and what have you, maybe that will be able to do. But my main point is a sense of equity, because as doctors, we feel like we are being pressed, and other professionals, they are emphasizing some of these issues which look very, very unethical. You go to a law, they tell you a non-cash bail, but somebody you have already paid 1 million, 2 million, but what's written on the paper is a non-cash bail. So is there a way at that senior level you can also have that interprofessional discussion so that we feel it is fairly being practiced across all the professionals? Thank you.
Thank you so much, Dr. Malone. Can we have, I think, a final question from Dr. Tendo?
Yes, thank you, Dr. Nakwagala, for this very informative presentation. My question goes to, especially in this era, we doctors, we usually have, we share our phone contacts or even emails with patients. And patients have leveraged on that to do phone consultations. And most of the times you want to be good, the good doctor, you know, you reach out, say, maybe buy this drug and etc. And in some occasions, we go ahead and take the history, but we don't examine because it's a phone consultation. However, on the other hand, as we are being nice and good, we are not charging for that. And also, so patients, or maybe I would say they kind of leverage on that because they know there won't be a cost attached to it. And also it's impinging on us as the medical profession. I would like to know what your comment is on that, in that regards, because become the norm of some patients going ahead, and also us trying to be nice and go ahead. But at the end of the day, it's not that we are not gaining the benefit of that, but it's also impinging on us economically. So kindly, I'd like to hear your comment on that with regards to phone calls. Thank you.
Thank you, Dr. Nakwagala. Over to you.
Yeah, I'll begin with Dr. Tendo's question. I find very interesting because I think on a day I get like 30 calls from patients who want phone consultations. And like you rightly said, you get into a dilemma. But what I decided to do, for example, I work in the area of diabetes. If a patient consults me over hypoglycemia, I cannot say, come to the clinic and I examine you. Because I know in the next 10 minutes that person will be in a coma. And I just decided to make it a free service that should any patient call me and in my circumstances I judge that this is hypoglycemia, I have to give a free service for that particular call. But for most of the times, many of the patients have turned our good turn into, I'll call my doctor wherever I am. They even tell you I traveled, I'm in Kenya, but actually they're just in their bar drinking, they're around in town. And that will kill the profession. So first and foremost, you don't do good service to a patient on a phone consultation. A phone consultation should just be a bridge to an actual service. The Medical Council has not authorized us to use phone consultation as a form of care. And actually, this very patient whom we are assisting on a phone service, remember, telephone service is a documented interaction. Can use that to take you to court and say, I was misadvised on a phone call, and therefore I'm claiming damages. And the council will not protect you as to why you guided the patient of a phone call and ended up getting injured. So phone call, I think, has limits, has limitations. We can use it for life-saving procedures, life-saving advices. I think it is very ethical for us to offer that noble service. And but we should do it not to the extent that people turn it into the actual service. Because again, I think in a court of law, if I give a sort of hypoglycemia, and even if somebody was armed, I can really defend myself. But if I prescribe a treatment, a cancer treatment on phone, I think in a court of law, I'm going to really be blamed over that. But secondly, I would like to advise us as a body of doctors, let us stop giving people free things, because people always want free things. We should only give free things when we really see that actually these free things are ethical to be given. But I even discovered that actually it is the rich people who want free things. Actually, peasants than the rich. But the rich have a lot of lunkulu. They feel that they're entitled to free. So they call you on phone and they even call you over complicated things. Yeah? I've got a fracture and they want you to treat them on phone of a fracture. Be very careful about that. So I want to advise us as a body that let us stop these free services so that people can meet us in our clinics and pay us a livelihood. So only help where it's life-saving procedures. And let's not do telephone. Also hasn't allowed us to treat people over phone, or unless if we come to that point. Olivia Stuka, thank you very much for the issue of moral distress, which is a very big gray zone. This is where I talked about judicious judgment. Because moral distress is a situation where you know what to do, but you can't do it because of the issues in your institution. So I'm sure that many of you go through it every day. For example, in issues to do with blood transfusion, there are times when there's blood for one person, but you have 6 people who need blood that night. And you go through that moral distress of whom you give this blood to. And when you are still thinking, you get a phone call from the director that give this blood to this yellow child. So you become confused and you become distressed. So I can tell you, I've read a lot about moral distress. There's no hard and fast answer about it, but you need wisdom, because sometimes you can take a decision against your institution and you end up being hurt instead. Sometimes you can play ethics and you lose your job that very day. So you need to be very judicious in your judgment. There's what we call milestone-based financing. So you go to an institution and they say, we pay you per how many NG tubes you've passed. And you find somebody is passing NG tubes in everybody. So you have to be very careful. If you haven't done 2 lumbar punctures, you get no payment that day. So you will struggle to make sure you do the lumbar puncture and pretend to put water instead of CSF in the tube. So moral distress is a very dangerous thing, and sometimes we ask people to get away from those kind of institutions, particularly if what they are telling you to do is criminal, including even if it's government which is telling you to do that. So sometimes the distress issues are where the criminalities are involved. There are some institutions where the ED of that institution tells you to do something which is against pharmaceutical guidelines. Are you going to do it? One of the ways is to walk away. One of the methods is walk away and look for another job. I've seen doctors who have left the profession, they have gone to plant trees. If that's the only thing that you can do, do it. So there's no hard and fast answer about moral distress, but be judicious, context by context, bear what you can bear, fight nobody, inquire. You can even share with your pastors, share with your imams, share with your mentor. This is, I think, one other area where mentors can be handy. Because remember, moral distress, so don't suffer it alone. It's very destructive, by the way. Share it with colleagues, share with mentors, share with seniors, share with supervisors. Then also, Ugandans are very shy. We are lucky now in Mulago, we have an administration which is very approachable. You must learn the art. Go and talk with the ED and say, Madam ED, I'm not comfortable with this. You sent me to work. Like I've always walked into the ED's office when there are no glucometers in Mulago. There are times when there are no glucose sticks for many MS for a whole month. I'm sure all of you use glucose sticks in your units. And it's very embarrassing that a patient comes in Mulago 4 days in emergency, and the patient is unknown, and you can't tell him to go and buy the glucometer. He's unconscious. You don't know whether the glucose is up or it's down. Either way, they go into coma. So what do you do? Until somebody said you get the urine from the patient's bag and test it with your mouth. You know, that's where the whole thing tells you to do. It's very dangerous when you're in a distressful condition. So whereas we don't encourage industrial action over A, B, C, D, I think we should be a little bit more assertive than what we are. I think Ugandans, we are very quietish. We just look on. We are only interested in agitating for salaries. But these are situations where within our units, for example, we can write memos to the ED and say, Madam ED, you know, this can't happen. Look at the issue of IPC now. It's not negotiable. Are you going to work without IPC in today's Uganda? Are you going to run a ward without running water, without soap, without jig, without alcohol? If you go down and wrote a memo Say, Madam Edie, we are here on the ward, we are working, but we can't work. Why? A, B, C, D. Madam Edie will come to you and will sort your problem. So I think we should also give some bit of gentle push to some of these systems. And I think when I see surgeons do it better than physicians. I'm not an advocate of strikes, but I'm an advocate of gentle pressure, a little more assertiveness than what we are doing. We are a little bit quiet, but let's continue with our work, but be a bit more assertive and claim from these people. Now, the issue of when money can't be paid by patients, this is the legal standard. Government says, and the lawyers have told us, that we should use all legal means of kubanjaring people. If somebody hasn't paid your debt, what do? Do you get a hammer and bang the person's head? No. No. The government argues that the dead have rights, including the right to be buried. So they say we should use alternative means of debt collection. And that's what we should be doing. You all have bad debtors. How do you handle your bad debtors? That's what we should learn. That's how we should do. You leave the dead, the people go bury their dead, and then you follow up your debts. All companies have bad debtors, and they have mechanisms on how to follow them up. And now the issue of who pays up in a private facility. Of course, you all know that it is a law in this country that you are supposed to stabilize every patient who comes to your facility and refer after stabilization without asking for pay. So if you are driving past IHK and a boda man runs over your vehicle or runs over your leg and breaks it, IHK is supposed to immobilize your limb, clean it appropriately, and give you TT and refer you to Mulago. So that is in the law. That is in the ethics. That is the standard. And you can't run away from it. So as far as the handling emergencies are concerned, stabilize and refer. So whoever of you is planning or has a private health unit, just make sure you have an ethical obligation to handle emergencies, stabilize, and then refer the patients that you have stabilized. And don't have continuity of care, because you can't claim that money from the consolidated fund in your private facility. So how does the law help us to get pay for emergency care? I think, as I've mentioned, you can't get pay for emergency care. Just know that you are helping, quickly help, and get the person out of your facility. I've seen Dr. Cheng is on the call. I would like to ask him to add on. Professor Cheng is one of the bioethicists in this country. He can also add on some of these responses. Professor Cheng, are you there? What is your take on some of these questions?
I think the Ocheng, I don't know whether it is Professor Ocheng or the Ocheng who is a medical student who is on.
No, I don't know. To Ocheng Joseph?
Ocheng, there is Ocheng, Ocheng Joseph, yes, I think this is Ocheng
He looks
Joseph.
like Professor Ocheng. Can he talk up? There are very few Ocheng Josephs in this country who can be on this type of call.
Tanakwagala, there is a student I teach who is called Ocheng Joseph. So it's the namesake. He's now in 5th year.
In our 5th year, okay, fine. All right. So I think that is what I want to emphasize here, members, is that these things don't have hard and fast answers. And that's why Aristotle said you must carry out judicious decision making. context by context, look at the risks and benefits of whichever situation you are in. I don't want you to turn into reckless people. I don't want you to stand before the PS and make a funny comment and then tomorrow you are transferred to Yumbe. So be judicious in your steps is my catchword this afternoon. I don't want you to be reckless and say, if that is the situation, therefore, I'm laying down my tools, and then after 3 days, you see you're regretting, why did I say that? Don't be reckless. Be in the middle. Learn to be a temperate person. Don't make rash decisions. Take your time, be cool, and live life. Of course, they say cowards live longer, but that is about cowardice. But I want to say that people who make judicious decisions make the best out of the medical profession, because there are so many pressures. There are so many. There are so many times you're going to be cheated. There are so many times you are going to be harassed. There are so many times you are going to be morally upset. But be judicious. You see light at the end of the day. Thank you very much.
Thank you so much, Dr. Nakwagala. I can see Dr. Kawere's hands are up. Let it be a short comment, since I'd already closed the questions, but please go ahead.
Thank you very much. I just wanted to ask a big question to all of us who are on this platform. Dr. Nakwagala, first of all, we really humbled to have you and talk to us, and being very honest and genuine and real. Sometimes other people fear to talk about facts because they fear to be labeled bad people, principled, or they don't know what they are doing. You find all sorts of things. But in a country like where there's a lot of disproportion, if I could say, in a country where there is the best politics, where politicians actually grip big and then they want to evade good services, but also they have their relatives fall sick, where there are a lot of infrastructure challenges, poor diagnostics, poor health services. Yet we know that some of those resources are squandered around. What advice would you give a young man who wants to survive, who just wants 1 million to be paid per month, and it is also being denied because he has to be very ethical? What would be your take, Dr. Nakwagala? Because really we are seeing this, that other people like politicians, they have billions to spend, they have budgets, they have everything, and they can do anything. But now for you who maintains their health, they don't want to make you survive. Over to you, Dr. Nakwagala. Thank you.
I think that is very easy to answer, Dr. Kaweru. A good doctor is supposed to be an advocate for the welfare of their client. So one of our pieces of work is to be advocates for policies, for budgetary allocations, for the macroeconomic picture orientation. We're supposed to be advocates even at that level. Myself, I've been hosted before by the National Planning Authority. I spent an afternoon with them, and I showed them how their NDP3 was not very favorable to health service delivery in this country. And I showed them how the population doesn't get the prioritization for healthcare. And I was happy when they came to NDP4 and I saw there were some improvements. It's not yet up to the level one would want to see, but at least I was happy that you can intervene as an advocate up there in those levels and create a change. Now, what we have been quiet about is exactly that as a medical profession. Sometimes I challenge my colleagues in the UMA that we seem to be so much interested in just strikes, but there's a lot we can do in agitating for advocacy. away from strikes, agitating for, upholding the health service delivery platforms to the point that they can be given what it deserves. Uganda is one of the few countries in the world which doesn't provide money for research. Our neighbors in Kenya devoted 2% of their GDP to research. We could do dialogue with our government and say, now that we have all revenues, why don't we attach 1% of all revenues to research? So there's a lot that we can do. And actually, in some of the medical codes of ethics, if you read it properly, you'll find that wording there that a good doctor is supposed to advocate for the welfare and the prioritization of the medical profession in general. And we are doing very badly on that one. So over to you, Dr. Kabweru and the UMA, you have quite a lot to do to agitate, to lobby, but with hammers and sticks, these people know how to create a future better than you. So go another language and agitate and talk, walk those corridors until they understand that you can't have 5% of your GDP on health and expect to have a healthy profession. You cannot have such lousy medical education. I must say that a good chunk of our medical education is very lousy these days. You can ask government how much they put to educate the doctors in the medical schools, the inputs. You find that they are very meager. You can't have that and expect the universities to give you quality doctors. Doctors are being trained with no reagents in the labs. You find it is donors. And some of us are very happy when these donors like Donald Trump pull out. It is time for us to learn to look after ourselves. I liked very much that controversial man, Donald Trump. It's now working out very, very seriously. Yesterday I was in a meeting in one of the government institutions, and there's a new thinking now. People are beginning to ask money from government because donors pulled out. And so for me, I'm putting it at that level that we should be advocates. We should be people who should be fighting. You see how these people in agriculture, they go to government, and almost all PDM money goes into agriculture projects at the village level. How much of that is going into health? It's because you and me are quiet. We're just looking on. So let us be advocates. Let us talk, walk and talk, and let us create noise, humble noise, not this hammering noise, but let's create that gentle until these people learn that health must be prioritized, and that health is a very important part of the development process of the country. Thank you very much.
Thank you so much, Dr. Nakwagala, for that this exciting presentation. I think we can go on and on. We are actually past our time, but it was worth the time. A few comments from some members. From Ian Shen Asimwe. He talks about the payment situation is very tricky, because I know situations where if the patient fails to pay, the money is recovered from staffs. But well said, the role of Hospital Clinical Ethical Committee is the way to go. And another one from Dr. Court Christopher, who says surgeons are still faced with problems of good work environment to produce the expected outcomes. At this point, before you log off, please drop your name and UMDPC number on the chat. Thank you so much for sparing time to attend this. Thank you. And we shall be having this every month. The next one is on the 26th June. We shall have a new presenter. So we hope to see you all there. Thank you so much and have a lovely day.
God bless you.
Bless you too, sir.